Our next speaker, a good friend of mine, Dr. William Ruiz. He's a board-certified OBGYN, board-certified in anti-aging and regenerative medicine, a specialist with over 30 years of experience. He focuses on functional medicine, hormones, transdermal hormones, very knowledgeable, and he's going to be talking just nuts and bolts and a primer on hormone replacement therapy with that focus on transdermal. So Dr. Ruiz, thank you, and come on over.
Still good morning, everybody, right? These lights are strong today, so I'll keep my eyes all the way down because I hate lights on my eyes. My name is Dr. William Ruiz. I'm happy to be for the second time here in this reunion. It has been a pleasure and honor. Last year, we were doing the lecture in Spanish. Today, it's going to be an interesting thing for me because all my lectures are in Spanish. I do not lecture in English, so in honor to all those people who come from States, we'll be lecturing in English. Dr. Ruiz always speaks in Spanish in his radio show with his PharmD students, so it's going to be a little bit challenging for me. So let's see what happens today. I don't have any disclosures to make. Said that I'm just a board-certified anti-aging medicine doctor. I practice OBGYN for 30 years. This year and a year and probably 3 months, I decided to finish my OB career, and I'm not doing deliveries anymore. I'm sleeping at home. My cortisol levels are down, and I'm starting to be very happy, and I'm looking younger. So I feel happy for that. Okay, today we're going to talk about bioidentical hormones, and this is a very hot topic in terms of what people says about hormones and cancer. And we need to understand that we need to redefine when we talk about hormones. In my past conference, in the very first summit, we were talking about what is the definition and what is the real truth about hormones and cancer. Today, I just simplified the conference just to point out the importance of bioidentical, the structure that we have in our bodies, and the way, in a very general way, how we could treat those. So, I think back. So, our objectives is to understand the connection between well-being, and this is the most important part, well-being and bioidentical hormones, because this is one of the pillars that you will need to treat your anti-aging functional metabolic patients. If there's something that we need to understand, that along life, one of the things that you will need, it's your hormones on track. If you don't do that, you will have issues along your life, and you will see that especially when you age, especially females, because they need estrogen to avoid dementia. Understand the difference of synthetics. We're going to talk about that a little bit in a minute. And bioidentical hormones, and of course be able to offer. That's the most important. That's why you are here, because after you redefine bioidentical hormones and synthetics, you will understand the necessity, the importance as physicians, as scientists, to really approach the patients in the better or highly quality way to treat any of the issues the patient has. You need to be able to have a nice and beautiful approach. And it's not that difficult. What are steroid hormones? So this is the very first things you need to understand in this morning. And they are biochemical compounds. They are secreted in 3 steroid glands. That we need to go back to basics to understand our body and know what's going on, because these hormones are leaving our body and we need to restore. Adrenal cortex, it's one of those. Testes, ovaries, and of course, in a beautiful time frame of the ladies, placenta is another organ that we need to understand a bit in terms of why estriol plays a role in this. All steroid hormones, all of them are derived from the evil molecule that we were taught when we were young students in med school and pharm schools, right? Cholesterol. Cholesterol has been an evil molecule. Everybody says you need to lower your cholesterol. But guess what? It's not entirely true. It's not about the total, it's about the quality of the cholesterol you have and if your cholesterol is oxidized or not. And they're transported, of course, through the bloodstream, and they go to different places and they do a bunch of things in our body, and they carry out a lot of things. And when I was studying in med school, it was this simple. So we have these pathways about our hormones, and it was very nice, interesting. You just learn about a couple things just regarding hormones. Nobody taught you how to understand them, just to treat them with conventional medicine, and that's it. And end of story. But it's more complicated than that. Now we have a pathway steroid where you can literally have all these bunch of things that you go into them, and you can spend in any corner of that pathway at least 1 hour in a lecture, at least 1 hour. And what nutrients, what lifestyles affect the steroid pathway. And that said, I have to include of course, all the medical literature that right now it's supporting what I'm saying. It's about 90 articles. You could just you're going to have this in your lecture. Just have fun in something that we always thought it was so difficult. Go with the pathway, look those references, look about the nutrients, and look how much you can do with your patients in terms of nutrients, in terms of lifestyle, in terms of diet, and how you can change the life of your patients. The trilogy of bioidentical hormone in my practice, it's about estrogen, testosterone, and progesterone. And of course, because I'm an OBGYN guy, of course, my 90% of my patients are females, so I treat these females with the 3 hormones as well. And now we need to define. Bioidentical hormone is the exact chemical structure that a human body has or produce. We need to understand that because if we will have here a chemist, I don't know if we have a chemist here in the house, these molecules can change when you add to the molecule, to the basics. They will react differently. And we know, and the medical literature states, that progestins, which is a different type of progesterone, stays more time in the receptor. So when it does, it will affect the body in different ways that we don't want. And we will see that in a minute. Okay? This is an example. Here's an example. Estradiol is the molecule. I love molecules. I used to love organic chemistry, and I was a little bit, hated by people because I like all these drawings. Estradiol is the natural hormone that the human has, but we have created ethinyl estradiol. As if you see, if I have a pointer here, there is another thing here in this corner. You have a triple bond. I know you know your chemistry. Triple bonds behave differently in the molecule. So we have a compound that is totally different from what our body is used to use and metabolize and excrete. So now we are having in our body a different compound that our body needs to deal with it. This is another example, progesterone and medroxyprogesterone. If you look very, very, very close, those are different molecules. And in a 3D dimension, when you create these molecules, you see here a 2D, when you see these molecules in a 3D, you will see that they occupy space. They're different. And of course, they have charges. And a chemist could talk a little bit more than me about that. That probably will interact in that receptor and will stay more time. And this is the issue when you use progesterone synthetics. The progesterone stays more time in the receptor, and it has a crisis in the cell in which the cell needs to get rid of it. It's stronger. It's a compound that's stronger than normal progesterone. Benefits of talking about bioidentical hormones and versus synthetics. A lot. I've been treating my patients since I can say my very first patient, I started on bioidenticals, and we had a beautiful relationships in terms of increasing doses, looking to how she felt. I cannot say her name, but let's say she's Mary, and she's not Mary. Mary and I, we had a nice and beautiful relationship in terms of her transdermals, and she was very open in terms of saying how she feels. And why is this so important? Because you will have an ample broad spectrum to use estrogen in females in terms of transdermals. Customize the same biochemical structure by the human body. Let me go back here a minute. Sorry, guys. Okay, we're talking about the benefits. We can reevaluate the patients. We can customize the prescription. We're using the same chemical structure that our body produces. And of course, this is the most important part. When you need to clear it out, when you need to metabolize, your body is already trained, since you were an embryo, to deal with these hormones. So it's very important that the identical hormones are cleared easier than synthetics. And that's one of the best benefits of bioidentical hormones and this approach. Let's talk about estrogens. And I think this is the challenging part, 3 by 3 by 3. Just remember that, and you will learn a little bit about this talk. Estrogen, it's complicated. His main message is to grow. So she doesn't see any other thing that growth. And that's why GYN doctors deal with a lot of abnormal uterine bleeding. Estrogens, another thing, 3 by 3 by 3. There's 3 types of estrogens in the body. Main 3 are estrogen, estradiol, estrone, and estriol. And not all of them are the same. They behave totally, and again, totally different. 3 by 3 by 3. So 3 estrogens. Now we have 3 areas, main areas in which we need to understand why we have some concerns regarding estrogens. Because we have 2 major receptors, the alpha and the beta. And more recently, now we have the GPR30 receptor. And it's interesting, this another receptor, because this is the receptor that the hormone hits rapidly and is really a non-genomic action of estradiol specifically. That's why when we get the hormone, people start getting better, but doesn't have the genomic strength. This receptor is not used in terms of genomic, but alpha and beta, those are the most important ones, and these are the ones we need to know and understand in terms of having issues with cancer-related problems. Alpha is the one that increases undesirable growth, and the beta, it's different. It controls. It's easier to work out with that receptor. It decreases growth. It helps prevent breast cancer, breast cancer development, and promotes the beneficial estrogenic effects of skin, bone, brain, and other tissues. And of course, I just already spoke about the 3rd receptor. So we have 3 estrogens. We have 3 receptor sites, and we have now the binding ratios, the 3 by 3 by 3, and this complicates things. We have seen that estrone activates alpha receptors in a ratio 5:1. Estradiol, it does this equally, a ratio 1:1. And E3, it will do preferably from the beta or to the beta receptor on the ratio of 3:1, and this might be or represents the reason why it can help and prevent breast cancer, because it helps tissue to stop growing, and that's very important, and it's very highly sustained, I should say, in the medical literature. A lot of people know me here, and a lot of people have heard me in the radio, and they know that I say always what I learned from my mentor, that in general, estrogen has over 400 functions in the body. So we're going to go over them in a nice way so you could encourage yourself to learn and read a little bit more. Number one, for women, improve sleeps. Ask the postmenopausal patients what's going on. They will tell, I cannot sleep. Give her estrogen, and you kill it. They start sleeping again. Metabolic rate increases. Insulin sensitivity improves. You can maintain muscle. You can prevent muscle damage. It's crucial in bone health because menopausal patient tends to go to osteoporosis, so we need that. And of course, estrogen are necessary for the production of acetylcholine transferase, an enzyme that we know prevents Alzheimer. Okay. Estrogen maintains memory. Estrogen decreases blood pressure. Estrogen has a positive effect on emotions. So girls that are in their reproductive age are more lovely. Ladies, they are menopause. They become a little bit more cranky. So they have issues dealing with interpersonal relationships. So we need to kill the E1 and hit with E2 so they can be more friendly, especially to their husbands. And that's the major concern that I have in my office. I see the couple when they're in the andropause and menopause timing. It increased the reasoning of new ideas, and that happens very much frequently more in women than in men. Decreases LDL, prevents oxidation of the cholesterol molecule. And this is a highlight thing to know because estrogen is an antioxidant. It enhances the growth and production of nerve growth factor and increases the water content, and I know the girls would love this, the water content of the skin, and it's responsible for the thickness and softness of your skin. Estrogen, for ladies, and we will learn that for men also, increases sexual interest. That's why menopausal patient that has estrone, not estradiol, which is from the reproductive age, will be more into have intimacy, different from the menopausal patient that says, I'm not interested in sex. I love my husband, but I don't want to be there. I hate my bed. I don't want to see this guy. I still love him, but I don't know what's going on in my body. It's because she switched from reproductive age to a menopausal stage, and she needs her estrogen rebalance. It reduces homocysteine. We just learned in one of the lectures, this is a substance that needs to take care of because it's an inflammatory marker, and we need to take inflammation out of our body if we want to be ageless. Decreases wrinkles, ladies, so you need your estrogens on the top of your list. Protect against macular degeneration, decrease the risk of colon cancer, and also aids in the formation of the neurotransmitter in the brain, such as serotonin. That's why when they get menopausal, they get depressed because they don't have the estrogen needed to produce serotonin. And when you give them, they have less depression, less irritability with their husband and their kids, less anxiety, and of course, helps in the pain sensitivity issues that through menopause patients have. Okay. Estrogen in the brain. One of our colleagues today in the discussion was talking about the importance of estrogen in the brain, and he just moved on. Here are the main highlights that you need to know. Increases blood flow in the brain, increases neurotransmitters, increases glucose and oxygen in the brain, protects neurons, keeps the blood-body barrier working properly, increases sensitivity to nerve growth factor, and decreases the neurodegeneration of the Alzheimer beta amyloid peptide. So you won't have Alzheimer's. So we know that people that use their transdermal will be better, and at the end of their life, they'll be living without Alzheimer's disease. Let's talk a little bit of estrogen and men. Interesting. Lady cells converts testosterone to estrogen. And this is important. Basically influences spermatogenesis, protect brain structures as man ages. So it's about estrogen in men too. You need to measure those. Is low, estrogen levels in men is low in patients which are Alzheimer's. So we need to see this in our patients to see what's going on in their metabolic pathway. Of course, estrogen in men also influences in bone because it has to do with bone maturation, has to do with regulation of the bone resorption. And of course, if it's low, your fractures will heal slow. Estradiol in men modulates libido. So it's important. It's not all about testosterone in guys. It increases also sexual interest. And it modulates erectile dysfunctions. Or function, I should say. So estrogen is part of the equation. It's not all about testosterone. We need our estrogens in the correct level. Low estrogens and female and aging. This is an article, it's very interesting. The use of estrogen in older women. We know that we treat patients since menopause for 10 years of hormone, and then you need to individualize. Those are the standard guidelines that we need to take into equations. And what we are seeing is that, especially us, the guys that are in the room, there are OBGYN guys here, when we go to OR and we take out the ovaries, what happens? The lady starts aging prematurely because she doesn't have the hormones that she needs. And this is a crisis that you see when you take out the ovaries or you have premature ovarian failure. And I have at least 2 patients in my clinic, which I use transdermals because in her early 30s, she doesn't have ovarian function and she needs estrogens. And literally this can cost her marriage, literally, because in 30s she's menopausing, and that's sad, too sad. So we know that estrogen has been linked and suggested when you have a deficiency as a stage of accelerated aging. So if you don't want to age, you need to see your estrogens. You need to look up them. Talk with your physicians, with your colleagues. If you want to learn how to do this, I'm welcome to help you guys. So now we're going to talk about the 3x3x3. Now we're going to talk a little bit of other hormones. One of the hormones that's manifested in menopause, estrone. It's the main one. It's the main one that the body makes postmenopausally. High levels of researchers believe that this is the molecule responsible for cancer. So this is the bad guy of the movie, and it's linked because when you metabolize and you clear and you go to phase 1, phase 2 detoxification, this is the molecule we need to get rid of. When I see patients and their highs 200s, 300s, 400s, estrogens, I worry a lot and say, we need to bring this down. Let's talk about estradiol. This is the beautiful molecule that we need in our females, and we need probably in our men. It's not an issue in our men because enough testosterone will push the steroid pathway to produce your own estrogen, so that's a good. So men are easier to fix than ladies. Ladies is a little bit more complex. Estradiol increases HDL, decreases LDL, and total cholesterol, and that's a good thing. So we need estrogens to work our labs in our patients in order to decrease this bad hormone that we have in our bad cholesterol that we have in our body, just giving the correct amount of estrogens. I'm fighting with my slides today. It also decreases triglycerides and help maintain bone structure. This is the main molecule that does that. Increases serotonin, decreases fatigue in females. That's why when you start bioidenticals and within 72 hours, the women starts feeling better and better. Works as an antioxidant and helps maintain memory. Ladies needs 17 beta estradiol in their brains. Helps absorption with calcium, magnesium, and zinc. So it really is probably a pleomorphic structure or molecule in which it helps in other things besides menopause. Direct effect, it does have a direct effect in the arteriosclerosis by reducing cholesterol accumulation in the arterial walls. So it's very important to treat early our patients in their menopausal stage to help them don't have that build up in their arteries. Let's talk about estriol, and this is the friend of placenta, the babies, the ladies there look so beautiful when they get pregnant. You see a glow, you see everything. Beautiful in pregnant females. Related to pregnancy, 80 times weaker than estradiol and has a lesser stimulatory effect. Considerable evidence exists that it protects against breast cancer. That's why we use it in transdermals. And experimentally has been used in breast cancer patients. It does not have, of course, the bone, heart, or brain protection as estradiol. That's why in my practice, I combine estriol with estradiol in a transdermal form in order to prevent cancer. And of course, I have to give them some estradiol so they can function properly and become a more lovely, nice, happier lady. Estriol. Let's talk a little bit about estriol. This is a fascinating compounded molecule which you can use it in the vagina. Benefits of the lining of the vagina. A lot of postmenopausal women still have intercourse, and of course they need to have their receptor organ on track in order to mate. Reduces pathogenic bacteria in the vagina. Controls symptoms of menopause in a lesser way. Remember, it's 80 times less stronger, but it does help. And the most marvelous thing that I see in this molecule is that blocks estrone. And this is the best thing that you could learn about estriol. Block estrone, the bad molecule, and occupying the receptor and sites so the breast will not grow. And that's what you need in breast cancer, a blockage of those receptors in order to maintain those cells on track. Let's talk about estrogen and metabolism after menopause. It gets complicated, and I told you estrogen is complicated, okay? Metabolism of estrogen change in menopause. Consequently, women will respond differently. They will differently. Another thing we need to understand are these two statements I have here. We have two major competing pathways from detoxification and clearance, and one minor pathway. 2-hydroxyestrone, we're not going to talk about all the pathways. I'm just trying to teach you why estrogen is so complicated. 2-hydroxyestrone, just 16-hydroxyestrone, and 4-hydroxyestrone, and I'm going to talk a little bit about all those so you can have a general knowledge and start your practice using, of course, transdermals. So we're going to be looking at that red box. We're going to work on that part right now when you're talking about detoxification and clearance of the estrogens. 2-hydroxyestrone pathway. What happens there? Simple. We need to methylate. If you methylate, you are good to go. Good estrogen metabolates when you methylate the estrogen and you clear it out and you have a particle that it's an estrogen, but it's a metabolite. You need to know how that molecule influences the receptor and the cell. So what we know that good estrogen metabolites, they do not stimulate growth. And it's important to push our patients when they're using transdermal in that pathway. 2-hydroxymethylations. What happens? Well, they block the action of stronger estrogens. So they compete. They compete for the bad ones, the bad guys, and they will say, we don't want cancer. We just want to clear it out, let the cells work properly, and that is all. That's the message we want to give. We want to have a healthy patient. And this is done by one of the enzymes that we know, catechol O-methyltransferase. It's the enzyme that's responsible for this methylation. And it's important to have COMT in our equation, and the patients will be doing this. We will know if patient is methylating well if we can measure one of the strongest things that we see in patients, that's homocysteine. And you can see it, if patients have high levels of homocysteine, this patient is not methylating properly, okay? Factors that support methylation, this is an easy one. SAMe, methionine, The B vitamins are very important. Folic acid, and there's a lot of things we could talk about folic acid and methyl tetrahydrofolate, and the people do not methylate well, or they have SNPs, or they have issues, even though you have folic acid in your equation taken every single day, you will not have the proper active molecule working for you. Betaine is one, and I believe, and you will see this a lot, that stress is a major component of patients who have poor metabolization of estrogen. So you need to reduce catecholamines and decrease stress. And this is very difficult because ladies, they like to be multitasking, and they like to do and do and do, and they are doers, and we just go back to our coach and sit down and relax, the guys, and they are doing and doing and doing. And we are different. Men and women are different. So we see people that they're trying to keep track because they need to feel that they can produce. And ladies, you need to go slow down at least 2 levels in terms of stress in order to help yourself have a nice metabolic pathway in terms of detoxification in your body. Ways to raise this pathway: moderate exercise. And I think everybody will say in this convention and this reunion that exercise is key. We could talk about peptides, we could talk about SNPs, we could talk about diet, we could talk about sleep, but we were created to move. If you don't move, you will die. So we need to tell our patients, get out of the couch, get out of the bed, move, be active. You need to sweat, you need to detoxify. Exercise is important. Of course, cruciferous vegetables, flax, soy, katsu, those are ways in which we could help our patients increase the metabolite pathways of 2-hydroxyestrone. Broccoli derivatives like indole 3-carbinol, DIM, omega-3 fatty acids are part of the equation. Of course, the B vitamins, rosemary, turmeric, weight loss, high protein diet, those are main factors in order to help our patient in the correct pathway metabolization, which is 2-hydroxyestrone. Let's talk about 16-hydroxy pathway. Has a significant estrogenic activity. It's a problem because estrogen was meant to grow. So if you have the main estrogen and then you have a metabolite that is also very strong, you will have problems. So we need to get out of that pathway, which is not the good one. And we know that when people go through this pathway, it's the one that's associated to increased risk of breast cancer. High levels are associated with obesity, hypothyroidism, pesticides, omega-6 fatty acid excess, and of course, inflammatory cytokines. And I know this topic high after COVID-19, so that's why a lot of people who had COVID, high cytokines, then after the pandemic, now we have a lot of people with breast cancer. A lot. It's because of this pathway. Now we have 4-hydroxyestrone. This is the bad one. It really damaged directly the DNA. It's proposed in the cancer development in the medical literature. And we used a lot of products in our practice for almost 30 plus years. Premarin increases this pathway. So now we understand why certain cancers came related to hormones, because we were using a synthetic hormone, which were inducing the growth and, of course, the wrong pathway for hydroxyestrone. It's present in greater quantities in the patients with methionine and folic acid. So what you need to know is you need to tell the patients you need to increase the use of folic acid and methionine in order to kick out that pathway out of your body. People who have uterine fibroids, myomas, are prone to have a 4-hydroxy pathway. And thank God, when you take the uterus out, you fix the problem and the patient will not have endometrial cancer. But there are a lot of people that we're still diagnosing endometrial cancer. So we need to address this pathway in the correct way in order to help our patients. Other factors that affect estrogen pathway, of course, alcohol, because it increases estrogens, and if you have a burden, an overload of estrogens in your body, of course you're going to produce estrone. It will convert, and of course you will go to the pathways, and then you will have a problem of risk of having breast cancer. Okay? So if you drink, don't drive. If you drink, please take your supplements in order to have less 4-hydroxyestrone in your system. So you have a cup of wine last night, look for the correct nutrients today, okay? Did I just jump one? No, that's the one, right? Yep, alcohol. Okay, so the secret. Okay, enough for saying it's complicated. Enough. I think you got the idea, right? Okay, perfect. Now let's go for the secret. The secret is to balance the equation. And that's what we do with transdermal. We work hard on balancing that equation. The past decade, we have working very hard on that topic, and we have demonstrated and we have seen the role of estrogen in a concept that we call balance or homeostasis in the body, and that's what we need in our patients. There's a nice article in 2017, Tumor and all his friends and colleagues are talking about the theory of estrogenemia. It's unifying the concept of the bad estrogens, the good estrogens, what we can do to our patients. So the key here, it's balance. So when I say balance, how do you balance? Of course, you need to measure. Okay? Another thing we need to do is understand why we need to go to the correct road. You need to go to transdermal. Oral versus transdermal, of course. There will always be patients on orals because health insurance plan, because there are other options. Try to get away of that because we know that oral conjugated equine estrogens are associated with thrombose. So you need to eliminate that risk factor of our patients. In contrast, if you use a transdermal like a patch, it's not associated with it. So the medical literature is clear about that. Even though the burden of estrogen can produce thrombosis, again, the important thing here is to balance the equation. And this has been written in 2019, okay? Physiologic impact of those oral things that we use in our practice decreases insulin-like growth factor, elevates liver enzymes, increases C-reactive proteins, increases gallstones, increases sex hormone binding, globulin, that you need to keep it down because then you will have all your hormones binded to a molecule that will not let those molecules, beautiful estrogen, beautiful testosterone work on your body. So we need to avoid that. It increases estrone when you take oral estrogens, increases triglycerides, it increases blood pressure. That's why it's important to address patients with estrogens transdermally. Increases the production of blood clots, and of course, you start on orals, you will see that they will gain weight. And they fight with you. Say, I don't like it. Nobody likes to get weight. Okay? So probably say, oh, I got some blue type for you now. Estrogen treatment. Better ways than conventional. Trust me, been in the business of doing transdermals I started in 2006. I was board certified in 2009. So I've been doing this for, make the numbers, since 2009. It's a lot of time. Why it's so important? It's an individualized therapy. Transdermal cream can be compounded. By a pharmacy, you can use different percentages between E2 and E3, depending on the patient you have. We call that bias because we have two estrogens, and it's the only method the only method of obtaining estriol in the US. Okay? So because of that, we need to get away of the orals and go back to the transdermals, in which we can compound, we can help our patients, we can increase estradiol, or we can increase estriol, depending. If you have too much, you have a family history of breast cancer, okay, we need to hit hard on estriol on you a little bit more. So that's why we'll see that a lot of compounded pharmacies, they will tell you, well, we have the compounded bias on 20% estradiol and 80% estriol, because we need to increase the amounts of estriol for those patients. Progesterone. We're changing the subject. I told you that we have a trilogy and we are our second hormone, and I hope I'm on time. Progesterone is made from pregnenolone. Progesterone performs many functions, and the function, I told you that the molecule of estrogen is to grow. So the molecule of progesterone, his main function is sustain, maintain life. And OBGYN guys know this. Sex hormone that plays a role in menstruation, of course, in pregnancy, of course, needed in embryos and implantation. Of course, it's made in the ovaries when the patients ovulate. So it's very important to ovulate in all those cycles in order to have your progesterone on correct level. After that, after menopause, you just switch to your adrenals. And if you have a stressful life with all those adrenals doing all those things that it does, when you turn to menopause, then you feel you don't have the energy because you're stressed. You're putting more effort on your adrenals so they can produce your progesterone. And it doesn't work properly, your progesterone from your adrenals. You need to give this to your patients. Promotes the formation of myelin shields, relaxes smooth muscles in the gut so the gut can absorb properly. And of course, we know that because controls estrogen, protects the breasts. Acts, when used properly, acts as a diuretic. It's an anti-inflammatory molecule. Aids in ovulation, of course. Balances estrogen. If you want a message of progesterone in this morning, you need to know that progesterone is there to control estrogens. So we know that when we're trained in OBGYN, oh, she doesn't have a uterus, you don't need progesterone. That's not entirely true. You truly need progesterone to balance the equation. Remember, it's about balancing hormones so the people can age less. Effects on the potential of GABA receptors. Of course, progesterone, people, when they're in progesterone, they feel sleepy. That's why we give progesterone at night when you give it PO, because people feels that they need to sleep. And it's because it goes to the GABA receptors. It enhances the thyroid hormone. So it's important. People are treating thyroid, and probably if you measure their progesterone, say, oh my God, something happening. Well, she's not ovulating properly, and probably she needs some of compounded progesterone. Helps build bone, helps maintain bladder functions, and that what happens when people ages and menopause. Maintains pregnancy, of course, that's a no-brainer there, okay? Helps prevent anxiety, irritability, mood swings. Restores proper cell oxygen levels, important. Helps the body use and eliminate fats. So it's not about semaglutide, right? Increases metabolic rate. And this is why one of the mechanisms most important that I believe why it's so important. Induces conversion of estrone to an inactive E1S form. So we will have a molecule that it's out of the equation here. So it won't be prone to produce cancer in our patients. Of course, progesterone decreases LDL and modulates the hormone of love. Modulates oxytocin receptor binding in the hypothalamus. So the weekends we need a lot of progesterone, right? So we can have fun with our spouses, okay? It promotes also Th2 immunity. It helps the the system of your immune system, the whole immune system, I should say, to help you in terms of being a healthier person. Just thinking of a pregnant patient, it's important that she stay healthy and her immune system be okay. Why? Because she is perpetuating the species, right? She's having a baby. So progesterone, which is progestate, pro-life, helps also in the process of helping life. Natural progesterone improves sleeps, leaves the body quickly, natural calming effect, lower high blood pressures, and lower cholesterol. Adrenaline hits the receptor of progesterone. I have a sign that I have to go fast now, so I'm sorry for you guys. 5 minutes, thank you very much. Progesterone in breast cancer. We know that people will have lower levels of breast cancer if they have good progesterone. Good progesterones come when you ovulate. So these ladies, they were measured, 6,000 females, during their premenopausal stage. And what they found that if you have good progesterone, you will have 88% reduction in risk of breast cancer. And that's a lot. Progesterone in breast cancer, they studied 1,000 females over 30 years, and they found that women that were deficient, 30 years, okay? 30 years seeing these patients. What happened? Women deficient were 5.4 increase in developing premenopausal cancer and literally 10 times likely to die from it, of any cancer. So does patient need progesterone? Of course, yes. Testosterone. Well, testosterone is an easy one. Increases sexual health, increases sense and emotional well-being, increases muscle mass, helps maintain memory. I need to come to this slide, which I want you to see, memorize. Please record it in your brain. Testosterone is a precursor of estradiol. And that's why men, when they are in their testosterone regimen, they are always okay, because they make estradiol from their testosterone, okay? It's a precursor. I will skip all this because I need to go to the treatment of testosterone in females because I have 5 minutes. There are no established indication for testosterone therapy in women. We need to understand that. FDA has not approved because uncertainties regarding to questioning the effective testosterone in females and long-term safety. I can agree with long-term because we need time for that. But in terms of how effective is testosterone, I totally disagree at this point. ACOG, American College of Obstetrics and Gynecology, has a statement on this, and it's only for female sexual disorder, and you should use it as a short-term thing, 3 to 6 months, and after evaluation to 3 to 6 months of that, you can change the therapy or do what is needed. Okay, what is the rationale of doing testosterone in females? 40% of postmenopausal women have decreased sexual desire, causing distress. Estrogen attenuates the vaginal complaints but has no effect on sexual desire. And here is an important clue that you must understand. So we need to put our females in testosterone for her complaints. Global consensus stated on 2010 that first we must optimize estrogens and then testosterone. Nowadays, we go to optimize both. Okay? Resultant transdermal testosterone in female. The results all were consistent with, I believe, 300 micrograms of testosterone, and in a patch, the number of sexual episodes were better, satisfying, increase of sexual desire, less distress related to sexual life compared to placebo. So, women need transdermal testosterone for their life. They have been studied with other dosages transdermally. Of course, we already know that the patch of 300 micrograms is the one to go, and we have seen a lot of studies how much the patient should need. Where we could go. Highlights of all these studies, what do they say? There is a lot of postmenopausal women, and they included healthy postmenopausal, and they saw that testosterone transdermally are not related to problems with blood lipids, blood pressure, insulin resistant, if and only if you are in the physiological points. If you go supraphysiological, of course you will have an imbalance. Concern, testosterone female, acne, and of course, hair growth in areas that you don't like. Of course, they start getting worried about that's too much, so you need to address that issue. And of course, long-term therapy, what we should do. Well, we're here for that. We're here for that. You just take care of your patient, do your labs, be responsible, and breast safety. We know that when we see testosterone-related patients and mammograms, we don't see that it increases density of the breast. In addition to menopausal therapy, we don't have cancer. We think that we counteract cancer, okay? You have that to read. That's a very two interesting studies. You can see they're not related, and testosterone implants. And we have endometrial safety. I don't have time for more. I was trying to go to the transdermal therapy. It's like a Rush 101 course on transdermal. I'm very sorry for that. It's because I explained it faster in Spanish than in English. And that's why. If you have any questions, how do I do? What do I do? Basically what I do, let's just jump all this so you could see the last thing that I do. This is my workup. Of course, you do conventional labs. Of course, you need to do hormonal labs. And I haven't spoke about saliva testing and urine metabolite testing. That's a whole universe that we need to discuss in another time. But they're very useful. I use them in my practice, and they are very powerful. And you have that slide. You could use it. You could learn from it. And you could call me. I will lecture, 5-minute lecture of how to use transdermals. And you can start your practice just measuring hormones and helping your patients. Questions? No questions? Oh, you know all this? Oh, you need to talk to me when we get out. Have a good one.
Thank you.